Hello, everyone, and thank you so much for joining us today. My name is Tiffany Tomaso, and I am one of the co-founders of Kensington Senior Living. My team and I are honored to once again partner with HFC to bring you our latest event, Care.Cure.Prevent. We have nearly 500 participants, so there is clearly a need for meaningful information, discussion, and even more so connection. When we started Kensington 12 years ago, an important element of our business plan was to be a resource for seniors and their families, regardless of whether they ever moved into a Kensington community. Over the years, we've done just that. At each of our 7 locations, we sponsor a myriad of educational events, we collaborate with local experts, and we financially support our local Alzheimer's associations and other nonprofits as they do special work for families and seniors in the community. Through our partnership with HFC, we've expanded what we were doing and can now support even more families as they navigate this difficult journey. Our panel today brings together some of the world's top neurologists who are driving initiatives to prevent and cure Alzheimer's disease and dementia. This dynamic, all-women panel, I might add, will share the latest breakthroughs in research and treatment options and offer recommendations about lifestyle habits that can help reduce the risk of memory loss. I now have the pleasure of introducing you to our moderator for today's event, Lauren Miller Rogan, founder of HFC. Lauren is a screenwriter, producer, philanthropist whose life has been touched many times over by Alzheimer's. In 2012, Lauren's mother was diagnosed with early onset Alzheimer's at only 55 years old. Lauren, still in her 20s, co-founded HFC to activate the next generation of Alzheimer's advocates. Since then, Lauren and the HFC team have brought significant awareness to Alzheimer's, raising millions of dollars to award free, quality in-home care to families in need of respite and support, all while using humor and hope to engage people. Her dedication to sharing her personal story and using humor as a form of advocacy has left an indelible impact on the Alzheimer's space. Since 2013, Lauren has served as the Alzheimer's patient advocate on the board of California's Institute of Regenerative Medicine. She also sits on the California Alzheimer's Task Force and the steering committee of the Milken Institute's Alliance to Improve Dementia Care. In 2012, Lauren starred in, co-wrote, and produced the film For a Good Time Call, which premiered at the 2012 Sundance Film Festival. Lauren made her feature-length directorial debut in 2018 with the dramedy Like Father, a film she wrote and which co-starred Kristen Bell and Kelsey Grammer. If there is one thing Lauren wants people to remember, it's that Alzheimer's doesn't have to be sad or scary when you're fighting against it. You can come to an HFC event, have some fun, but also do something meaningful for Alzheimer's. And with that, I welcome Lauren.
Thank you so much. I'm so excited to be here. As Tiffany just said, I am hugely passionate about changing the course of this disease and helping caregivers lighten the heavy load they're usually carrying and teaching people how to care for their brains. My family got a front row seat to this cruel disease when we cared for my mom for the 16 years that she battled with it. And I can understand how exhausting and how thankless and how hopeless Alzheimer's can make someone feel. But I also understand that today there's hope, and stories of caregivers are coming to light and starting to end the stigma. And although we may not have a cure yet, there are more and more studies every day which bring optimism and hope. and what I've learned about brain health and Alzheimer's, that Alzheimer's may actually be preventable in some cases, I'll just say that I have so much hope for the future and that one day Alzheimer's will actually be a thing of the past. So with that in mind, again, I'm thrilled to be here and have this conversation with these 5 incredible women who are top neurologists. We're going to do a roundtable discussion where I'll ask questions and everyone will have a chance to answer them. Everyone submitted their questions in the registration, so we have all of your questions, everyone that has joined us here. So don't worry, we're going to try to get to everything. We won't get to everything, but we will record today's webinar. You'll get a copy of it with your friends. We'll make sure every question that was submitted is answered to the best of our abilities. So it is with great honor that I am going to introduce each of our panelists. And we will get started. So first, I would love to introduce Dr. Mindy Azen. She is a clinical professor of neurology for the Alzheimer's Therapeutic Research Institute at the University of Southern California Keck School of Medicine since 2009. Her past academic positions include associate professor at Cornell University Medical School and professor at Georgetown University. She is board certified in neurology and neurorehabilitation. These women are very impressive. Okay, so next we have Dr. Jessica De Leon. She is a behavioral neurologist and assistant professor of neurology at the University of California, San Francisco Memory and Aging Center. She received her undergraduate degrees in neuroscience and Spanish at the Johns Hopkins University and obtained an MD with thesis degree at UCSF. She then completed her residency in neurology and a clinical and research fellowship in behavioral neurology at UCSF. I mean, again, it's really impressive. Okay, next is Dr. Sarah Kremen. She is a behavioral neurologist and the director of neurobehavior program at the Jonah Goldrich Center for Alzheimer's Memory Disorders at the Cedars-Sinai Medical Center. She completed her residency in neurology at UCLA and her fellowship training in behavioral neurology and neuropsychiatry at the Greater Los Angeles VA Medical Center. Then we have Dr. Layla Parand. She is an assistant clinical professor of neurology at the David Geffen School of Medicine at UCLA. Her specialties include neurology, Alzheimer's disease, memory disorders, dementia, and neurobehavioral. What a combination. And then last but certainly not least is Dr. Sharon Shah, who is a clinical professor, associate professor of neurology and neurological sciences at Stanford University, where she serves as associate vice chair of clinical research, co-director of the Huntington's Disease Center of Excellence and Ataxia Clinic, co-director of the Lewy Body Disease Association Research Center of Excellence, clinical core co-leader of the Stanford Alzheimer's Disease Research Center, and director of the Behavioral Neurology Fellowship. I have degrees in fashion design and film, so these things are just beyond. But anyway, why don't we pass it around to each of you to sort of give a little overview, just sort of a brief introduction of who you are and your area of interest in neurology. Should we start with Dr. Shah?
Hi, Lauren. Thank you so much for that wonderful introduction. I'm truly honored to be here with everybody, and I want to thank everyone who organized this, Susan Evans, and I really thank you all for your hard work. So, I feel truly sort of blushing when you're introducing me. I'm really committed to taking care of patients with dementia. I specialize in dementia syndromes. My goal in my career is to find a cure someday. So I'm training the next generation to help take care of patients. And in the time I'm not seeing patients, I'm working on clinical trials and finding research that we can find that cure someday.
Amazing. Dr. Kremen, you're up.
So thanks also for the invitation. It's really exciting to be part of this event. So much like Dr. Shah, also I take care of patients and care so much about helping them get the information that they need when they're experiencing difficulties and trying to understand disease processes. Again, a lot of what I'm seeing in clinic is similar. We're all, seeing people with Alzheimer's disease, dementia with Lewy bodies, and primary progressive aphasia. And so we're here to, really try to help patients. I really want to help them understand what's happening and what's going on in the brain, and also help them again find a clinical trial and help them navigate also the non-pharmacological things, just trying to manage behavior and get through the day.
Yeah, so important. It's so tough. Do the other panelists want to turn their cameras on? I assume you're here. Yep, here we go. Hello, everyone. Hi, there are your amazingly beautiful faces. Dr. Paran, do you want to introduce your work?
Sure. I work in the memory clinic here at UCLA, and I see patients with a broad spectrum of cognitive and behavioral disorders. I also work with the clinical trial team here.
Amazing. Dr. Azen?
Hi, everybody. So I was in medical school when some of you weren't even born yet, actually. I was in medical school in 1970s, graduated in 1980. And during my career, I took care of a lot of patients, including a lot of people who had profound cognitive impairment and progressive cognitive impairment. I thought what would be most interesting in my introduction would be to describe where I work today, which is the Alzheimer's Therapeutic Research Institute, in which we do not see patients directly, but rather coordinate clinical trials throughout the world, over 100 sites. And we are actively exploring and trying to prove whether things work or don't work, whether they are going to stop the amyloid deposition in the brain and reverse it. And there's a lot of hope there. We're also looking at the latest diagnostic tests, and in addition, somewhat clinical treatment that is management of the symptoms, what might boost memory a little better. And we hope that this helps feed the clinicians out there the information they need and helps get the appropriate agents approved and out there for people. I wanted to say one thing just to try to help people understand where money in research goes. So Kensington generously donated $1,000, I think, to each of our institutions for our participation today. And I think that's really generous and wonderful. And so what does $1,000 pay for in clinical research? Well, it pays for one blood test for the new amyloid peptide test. And we're hopeful that that is going to be the way to definitively diagnose Alzheimer's disease without a brain biopsy and without an autopsy, but rather in a blood test, and even pick it up before it's symptomatic, so we can truly prevent it. So that's what $1,000 buys today. We're not there yet, but there is a lot of reason for hope, and this is the way to get there. Thank you.
Amazing. Thank you. I think putting it in those terms is really helpful, and clinical trials, boy, are certainly key to changing the course of this disease. So we're so excited to talk to you further. Dr. DeLeon, you want to give us a little brief overview of your work, and then we'll dive into some of these questions.
Yeah, thanks, Lauren. And thank you to the organizers for inviting us here, for putting this panel together. I think when I reflect about how I got here, I think it all started with my own family's experiences with neurologic diseases, and things just blossomed from there. I have a particular interest in the language symptoms that happen in dementia. So symptoms like word finding difficulties, trouble with comprehension. I can really see how those really affect quality of life and a lot of the social interactions that are important for us and for people with dementia and for their loved ones. And this has informed what I do in research. I study how symptoms might differ depending on what language someone speaks. So for example, someone who speaks Italian might actually have different symptoms from someone who speaks Mandarin or a tonal language. So we're trying to develop better tests for people who speak different languages. So thank you again, and I'm excited to see how today goes.
Yeah, amazing. That's fascinating. So excited to hear about everyone's work and everything. So let's dive in here. Why don't I try not calling on someone? Jump in if you feel like you want to answer this question. Otherwise, I'll call on someone. So get ready. But basically, let's sort of start at the beginning, which is, what do we know about Alzheimer's disease? How does it fit under the umbrella of dementia? And also, how does early onset fit into that umbrella of Alzheimer's disease? Anyone want to dive in?
I'll take it. I'm ready.
Do it.
So I get this question a lot about what dementia is. How is that different than Alzheimer's disease? What's mild cognitive impairment? So I usually start with some definitions. So typically what I like to say is mild cognitive impairment and dementia are both umbrella terms. And what does that mean? I like to compare it to, say, knee pain. knee pain can be caused, it's a diagnosis, but it can be caused by trauma, infection, arthritis. So mild cognitive impairment and dementia are sort of definitions of a cognitive change or behavioral change. And the difference is that dementia, if you have a memory problem, it impairs your ability to take care of yourself. So that might be paying your bills. It might be doing your shopping or cooking, taking care of, remembering to take your medications. Whereas mild cognitive impairment typically means that you have independence in living by yourself, but you're basically able to compensate with those memory problems or whatever the cognitive impairment might be. So if you think of that umbrella of dementia, there are different kinds of dementias, Alzheimer's disease being the most common type of dementia. And we tend to think about it with memory loss, word finding, navigation difficulties, and mild cognitive impairment and dementia are on a spectrum. So it's not like you wake up one day, I have mild cognitive impairment, tomorrow I have dementia. It's sort of a trajectory, but we have that underlying cause of likely Alzheimer's disease. And then the last part of your question is what's early onset? And typically we've defined that as less than 65. Anyone else can add to that, please.
Does anyone want to chime in there?
Yeah, I think what Dr. Shah said is exactly on point. Maybe I can add a few more details about what early onset Alzheimer's might look like. I often get asked that in clinic. It's much less common. So maybe about 5 or 10% of people develop an early onset Alzheimer's. And as Dr. Shah said, we define that as someone who comes in before age 65 with symptoms. And usually if someone's going to come, it's going to be in their 50s or their 60s. There are certain types of familial or inherited Alzheimer's that can present even younger, but they're quite rare. And then I often get asked about the symptoms, if the symptoms are different. And they're often quite similar to the Alzheimer's that happens later in life. Maybe a little more, I guess what we say like focal, where it might seem that someone has more visual symptoms, or maybe just more language symptoms. Maybe because there just isn't as many co-pathologies, a lot of different things happening in the brain. But they become more kind of all together as someone develops and moves on in the disease.
Yeah, as we talked about, my mom was 55, although I've heard someone that I know has speculated that she had Alzheimer's with an onset that was early and not early onset Alzheimer's, which there's a difference. Does anyone want to speak to that? I saw Dr. Kremen nodding.
I'll jump in. So usually when people ask about early onset, what I'd like to say is that about 1% of all of Alzheimer's cases are really these very familial autosomal dominant, meaning if you get a gene, if it runs in your family, it's autosomal dominant, meaning if you get a copy of that gene from a parent, you're going to get Alzheimer's disease. But these are, it's really rare. It's less than 1%, and it's really runs in families. And people know because generation after generation after generation of many siblings will have this disease, and they're getting this in their 30s, in their 20s, in their 40s. And there is a whole group of cohorts that are being followed in the dominantly inherited Alzheimer's network, where we are looking in that population to see if we have clues to better understand. And since we can sort of determine when people are going to get the disease within that cohort, trying to understand better how that develops, and if we can take that into the general sporadic, more common type of Alzheimer's. But early onset, otherwise, to your point, is, those 1% are due to genes like presenilin 1, presenilin 2, APP. Most people do not have that gene. So when people are coming in asking if they should get tested, no, probably you don't, unless there's some real strong family history. Then there's people who are under the age of 65, of which, Dr. DeLeon was talking about, and they are still not very common, but it exists. It's maybe 300,000 people. I mean, that's it's probably not everybody who's counted, but it's an estimate. And we're not exactly sure of all the genes, because what we're finding out is that Alzheimer's disease is complicated and there's many genes, although the most common one that people might have heard of is ApoE4. So yes, there might be an association with ApoE4. We know that people who have a copy of the ApoE4 gene, 1 or 2, they might get the disease earlier. They tend to get the disease earlier, but even then, you don't have to have a copy of ApoE4 to get Alzheimer's disease. But the bottom line is that it's still the most, the risk factor for Alzheimer's disease is aging. So most cases of Alzheimer's disease are really going to be typical onset, not early onset.
Yeah. Yeah. Thank you for that. So much to learn, so much to cover. I feel like most people are pretty, aware of some of the symptoms. But let's talk about, you see your loved one showing some signs. What do you do to get a diagnosis, and then after a diagnosis? Let's cover that one. Anyone want to dive in there? Dr. Azen, you want to take the one about receiving diagnosis? What is the process like there?
Sure. So the first and most important thing is to find out, is there a treatable cause for the brain failure, for the losing memory, the difficulty learning new things, solving problems. And there are very treatable causes for that. Hypothyroidism, certain vitamin deficiencies, B12, certain infectious diseases. So it's very important to get the fundamental workup to know if there's a correctable problem. Then, if there isn't something identifiable underlying a metabolic problem, a series of cognitive tests can pinpoint whether someone is sort of globally functioning less well versus focal memory problems or language problems. The diagnosis has changed so much in my lifetime, let alone the millennia that we've known about dementia associated with getting older. And like I alluded to earlier, it used to be, when I was in training in neurology, that the only way to fundamentally diagnose Alzheimer's disease was, well, with the brain biopsy, which we weren't about to do since there wasn't something to do about it, or autopsy. Things have changed so dramatically in the past decade. And so now it's possible to do imaging, which will reliably tell you whether the person has Alzheimer's disease or not. And as I mentioned earlier, very soon there will be accurate blood tests that can do that. And these are important, not only, as I was alluding to before, to make the diagnosis, but in addition to know whether certain emerging therapies might be beneficial. That's a whole other conversation.
Well, on to that. So let's talk about that. When my mom was diagnosed 15 years ago, there were, 2 medications, none of which did anything. Not that there's a lot now, but let's talk about some research studies that are happening. How important is it to participate in a human trial if one is available to you? Let's talk about that for a minute. Who wants to jump in there?
Well, maybe I can respond to that, and then I'll be quiet for a while. Things have changed so quickly, and I think it maybe people on the panel know my husband is one of the people who very vocally advocated for the amyloid hypothesis, and he's been, even though there's no conflict of interest, and unfortunately we don't have a big chunk of Biogen, but people have sort of associated him with the aducanumab, the newly approved drug, which he actually did not have a part in. But right, so the medications your mom got, my mom got, basically were to boost memory, and they help a bit. And there have been a lot of Me Too's since the initial one came out, and sometimes one's a little better than the other, but they aren't really the answer to much. But now these treatments may truly help. And the aducanumab story is long and interesting, and I don't know that we have time or that everyone else would find it that interesting. But the fact was that they first stopped the trial with it. And then when they re-looked at the data, they realized that, in fact, the drug was working. That is, it was pulling amyloid out of the brain. And when they diced and sliced the data, they realized that people were legitimately experiencing slowing of cognitive impairment. And the controversy about it has been that the FDA didn't follow all of the usual protocols for approval, and whether they were influenced by the advocacy groups, for example, the Alzheimer's Association and others, who simply were saying, we have nothing else, don't stand in our way. Who knows? I can't say. But that's what people have objected to, that all of the usual processes weren't followed, and that this particular drug may have been approved earlier and without the kind of rigor that others have required. However, I mean, people would ask me the question, if it were you, because unfortunately my parents aren't alive to experience this anymore. If it were me, would I do it? Yes. And if it were a loved one and there was nothing else out there, yes. But it's certainly not the answer. And there are many other agents that attack the amyloid and the tau in different ways, and they are being studied actively right now. So the only way to access some of those treatments are to participate in trials. And the other point is, it's the way to advance the field. It will be safe. And without any other alternative, I would advocate doing it.
Yeah. I mean, I think the thing about science is you have to try all these things. I'm curious what anyone else thinks about, any, trials that you know of that are interesting, and also the importance of participating in trials is something, I think we should touch on.
I'd love to say something about that,
please.
if I may. It's really, it's really a passion of mine to try to find something, especially seeing patients day in and day out and sort of saying, what do you have left? This medication, as you said, Lauren, is what your mom got, and this is what we've had for decades. And so when I see a patient, I saw someone just yesterday who's, 60 with Alzheimer's disease, and to answer the question, why is he getting the diagnosis now at this age? And we don't know. And as Dr. Kremen mentioned earlier, sure, we can think about some risk factor, genetic mutations, we can think about lifestyle measures, but a lot of people have done all the right things in their lives. So the importance of volunteering for research is to understand, not only for yourself, but everybody else, why someone young might get the disease, why a woman might get the disease, why an Asian woman might get the disease, why an African-American man might get the disease. So unless those people participate in research, we can't answer the questions about whether the treatment might work for you, whether the treatment might work for someone else like you, or even understanding the questions of why this disease is actually so heterogeneous. What we're saying is this is Alzheimer's disease. We know that there's the same pathology of amyloid and tau that builds up in the brain, but what makes someone vulnerable at 50 versus 85, we have yet to understand. So this is why we need to get everybody participating in research.
Yeah. Dr. Kremen, I saw you nodding. I'm curious what you have to add.
Yeah, I was going to add to what Sharon said, because it's really true. I mean, there's so many things. For example, now, if you look at how we start blood pressure medications, that's informed by the fact that there were different communities that participated. So now if somebody is white versus Black or African-American, we'll start you on a different type of medication based upon that, because there was research done looking at that. And it is true, we don't understand all the risk factors, but we're adding them all the time. There's a really great paper that came out in 2018 that was updated recently by an international working group looking at risk factors for developing dementia. And we know that over the course of lifetime, there are different types of risk factors where we are particularly more vulnerable. So again, genetics, it turns out it only makes up like 7% of your risk, right? But there's all these other things: early childhood education, midlife, you've got smoking, exercise, later life, you've got hearing loss, you've got depression, less social contacts, pollution now is on the list. And I'm sure that this paper, it's going to be revised again, because on there is not sleep, for example. We know sleep problems also contribute. So there's, and gut microbiome health, that's like a whole new area that we didn't even consider before, that now we're thinking might actually be very important. So there are so many risk factors to look at, and we can't know that unless people jump in and help us help them. We're so interested in trying to understand why these neurodegenerative diseases develop.
Yeah. Before we move into some of the things that you just touched on, which I think go into the prevention and health of it all, how does someone get involved in a trial? You get the diagnosis and you're like, well, I'd like to try this or that. And maybe your local doctor isn't the right one. How do you find a good trial to participate in? Anyone?
I'll say something. So I don't want to just steal the mic, but I do like talking. So I'll keep going.
Please.
This is
a loose discussion. We don't need to be formal about it. So
there's a lot of advocacy groups, and Alzheimer's Association is quite popular. So that's a great resource for looking about education materials and finding out what might be active in your area. Clinicaltrials.gov is another resource. It's a little bit more data driven, so meaning that's a little less flashy to find what you're looking for, but definitely everything must be listed if there's a clinical trial there. May not be as updated as to whether it's in your area or not, and then you can definitely look at into different institutions near you, whether they're offering a clinical trial. Or you can ask me, reach out to me, I'll tell you.
And we had a note to talk about support groups, which I'm going to comment on, as someone who, my mother went through the disease, I think as caregivers, we can get focused in caring on the person with the disease, which of course is hugely important, but you have to also care for yourself. So as important it is to get your loved one into a clinical trial, it is also important to get yourself into some sort of support group or therapy or support situation. Does anyone want to talk about that?
Here at UCLA, we offer a support group for early onset dementias, as well as people who have Alzheimer's later in life. And it's helpful because sometimes if it's early onset, then there are people with young children and they have different types of needs. So it can be very helpful. And some people have to find the right fit. They have to look for the support group that fits right for them, either through the Alzheimer's Association or through the university setting, feel where they feel comfortable to really open up.
Yeah. No, I think it's one of those things that, you can feel so alone and so isolated as a caregiver. And, I'm sure many people have heard that, caregivers often get, more sick, and you often can lose a caregiver before a loved one with the disease. So taking care of your health when you're a caregiver is so important. I think that's actually a good segue into, health and, the things that we can do potentially to decrease the risk of Alzheimer's disease, or if we can say that, I think we can. I've learned so much myself over the last, 5-6 years about brain health. And I think there's just, a lot of exciting stuff going on. So, let's start. There's so much to say. Let's start with, I guess, what are some of the overview, the ways that you could decrease the risk of Alzheimer's and maintain your brain health? Dr. DeLeon, you want to take that one?
Yeah, I can start. I bet we're going to all chime in. Dr. Kremen hit a lot of really good points about this. A lot of this comes down to lifestyle factors. So we will often talk about like a Mediterranean diet, lots of fruits and veggies, exercise, trying to keep blood pressure and diabetes under control. Another piece is keeping our minds active and engaged. And I think that's been a little hard, right, this past year during the pandemic. I guess, about that, something that I found that actually, if any of you have heard about awe walks, as a way to just kind of keep our brains engaged. It's really simple and easy to do nowadays, even when things are closed down. Just involves going outside, taking a walk, trying to focus on something outside of yourself, just getting into nature. So I don't know if it's looking at the ways that leaves are changing on the trees. My kid is now obsessed with shadows, which I never really thought about. I mean, it's kind of just attached to you, right? So it's not something I think about very much anymore, but just finding joy in that. There was actually a study, it's actually a very simple, very elegant study that someone did here at UCSF, Dr. Sturm, and looked at selfies, how people felt when they first started these all walks and what happened after a few weeks when they were doing this regularly. And you could just see even in their selfies, their smiles, just how much of an effect it had. And it's really quite simple. So I'll start there.
That's amazing. Who's next? Does someone want to talk about diet? No one wants to talk about diet.
I'll talk about diet. Sure. I mean, whenever I tell patients and families, well, first I wanted to touch upon what you said, Lauren, about caregiving and the burden, just because I can't help myself. I always tell patients that they and their entire family are my patients, because if I tell a patient what to do for themselves, it doesn't really work unless I'm telling their caregiver and their family and the entire unit. So if we're talking about lifestyle factors, it has to be the entire unit, because you can't just give the patient necessarily, here's your prescription of a Mediterranean diet, a heart healthy diet, but then someone else has fried chicken in front of them. That's my weakness. So, but I think in terms of diet, what's been studied the most is a Mediterranean heart healthy diet. It's fuel for your body and your brain. But, there's some cultures where they may not be familiar with a Mediterranean diet. So I think that's what the other thing is, that if there are other cultures that haven't been studied as much, well, we think about what might be in that Mediterranean diet, such as, lean proteins, leafy greens, a balanced diet, less fried foods. So, knocking out that fried chicken from the menu can help support that healthy lifestyle. And then what I usually say to my patients is exercise, exercise, exercise are my 1, 2, 3, and because of the pandemic and isolation, I've actually really implemented not just the heart rate pumping you up exercise, that aerobic exercise has been studied the most, but I think some sort of wellness exercise, disconnecting from technology. There's some studies to demonstrate that nature really provides better attention as well. So something that's relaxing in addition to that exercise. Dr. Kremen mentioned sleep. It's so important. We're understanding how much it really helps your wellness, helps with concentration, but research studies are showing how much it helps decrease the risk of developing things like Alzheimer's disease, because it helps get rid of those bad proteins while we're asleep. So I'll stop there and let other people chime in.
All right, well then I'm going to jump in, and I'm going to jump in with mental health. So one of the biggest things that's really important is taking care of mental health, which unfortunately is still really a stigma, and also is hard to take care of because of the way the medical system is set up, where it's expected that, after 10 sessions with a psychiatrist, your mental health will be better. Whereas, we would never do that for diabetes or a heart condition. It's really hard. So we know that if you have depression, it increases your risk for dementia later in life. So does anxiety. And we think that some of these conditions actually are very inflammatory. They're not good for our brains. Not only are they not good for your own psyche and your well-being and dealing with things every day, but probably on a cellular level, it's not very good either. And so it really is important to do an assessment of somebody's mental health. Are they feeling anxious? Are they feeling depressed? And let's do something about that, whether that's non-pharmacological by exercising, because exercise helps with everything, or getting involved socially, or doing something where you're using your brain that you enjoy, that you're going to engage in, or whether you need pharmacological assistance as well, and other kinds of psychotherapy, whatever that may be. I think it's also important to realize that, we also think that in some of the neurodegenerative diseases, it may not be the cognition that pops up first. It may actually be a behavioral change of more anxious, not, feeling more depressed when someone hasn't had that their entire life, or maybe it's becoming exacerbated. That's really a sign that something we need to be looking at, because it may be a harbinger that there's something else going on in the brain in a neurodegenerative way. So mental health with exercise and a good diet.
Yeah, it's hard. I think that, as someone who's been talking about brain health and for a couple of years, I think one of the things the 3 things that are daunting, of course, are diet and exercise, and how do I improve my sleep? I think is one that people are often, so it's a mystery, is how do I sleep better? And I have to just share from experience that you can improve your sleep. There are a number of devices out there that you can use to track your sleep. I'll just plug HFC as a partnership with Whoop. You can buy a Whoop band and also support HFC. It's an activity and sleep tracker, but there are a number out there, but I can say that through having a consistent bedtime, through getting a device that cooled my bed, keeping my bedroom extra cold, I cool my bed and I use a weighted blanket, which is silly, but because I track it, these things have improved my sleep and it is doable. And so there are really, practical things out there and you'll be happier if you improve your sleep and also with exercise, by the way. I'm curious if anyone wants to speak to particular types of exercise that are more beneficial. I've done research and heard things about HIIT exercises. Of course, having muscle on your body can be beneficial. Does anyone want to touch on the types of exercise that are the most beneficial? Dr. De Leon, I feel like you have an answer at the tip of your tongue. I see excitement.
Oh, well, I'm just laughing because I'm looking at my treadmill. Yeah, so I'm always happy for anyone to start from scratch, right? So we don't necessarily mean that you need to run a marathon tomorrow. It can feel really daunting, especially if you really are not doing much. So I like to tell people to try to aim for something moderate, right? So something where you are, raising your heart rate a little bit, but still able to hold a conversation. And having some cardiovascular in there is great. Choosing something that you enjoy is a huge thing as well. So I'm not going to say that you have to go swimming or you have to go running if you absolutely hate it. So I think, something cardiovascular. There's some research into HIIT and keeping that muscle on as well. And I'll let others jump in as well.
I was only going to say that for patients specifically, who might have joint problems or never exercise in their life, it might be hard to say, go exercise 30 minutes a day, if you can trick your mind into making it a routine and say, well, do you like music? Do you like to dance? Why don't you just turn that up and move around, or if you're going for a walk, just walk a little faster, walk a little longer. We can all exercise. So it really depends. I think the goal is to get that aerobic exercise and also have the wellness in there too. But if you could socialize and keep your brain stimulated at the same time, even more fantastic. If we're starting from square one, then do something that's attainable. And I always tell people, do it daily. You can't say, 3 times a week. When I tried to do that after my second kid, I'll just do it every other day. It was never every day. And it was never 3 times a week. Right. If you make it part of your daily routine, it'll happen.
Yeah. It's, and I also, when I started on this journey, and my doctor was like, exercise. And I was like, I'll never be one of those people that says I enjoy exercise. And I do. And I've been sad. I would do HIIT workouts through Orange Theory, which is one of the many gyms out there, and not going because I can't do it with a mask on. It's too much breathing. But but it's, you can get addicted to what works for you. And I think that's what's so important. My husband hikes. We have a trail that's sort of somewhat near our house. And he's found that doing that and it's a great cardio workout, and it, is steep and builds muscle. And I think, exactly what we said, you have to do what works for you as far as exercise goes.
I'll throw in there too that, you don't have to do the 30 minutes all in one go. It's cumulative for a day. And so for patients who are starting from scratch and have not been excited about exercise, or say you've got, a knee problem or a hip problem or a back problem, and you can't sustain too much, then just do a little bit at a time and, make sure that by the end of the day, you've done a half an hour, and that's okay. That's perfectly fine. Yeah. And definitely attainable. You can do something for 5 minutes and just break it up into 5 minutes if that's what it takes.
Yeah. And there's so many apps these days that will do a short workout, and also another element is meditation, of course, is hugely important, I think, to your emotional well-being. Speaking of apps, I have an app that, reminds me to take some breaths every few hours, and, I literally for 3 minutes will sit and breathe. And I think these things are so important, especially when you're in the midst of caregiving, which can be so just overwhelming and 24/7 at times, to be able to find a minute to catch your breath, because that is, hugely important, just to rest and reset your mind, for the huge endeavor that is caregiving. Before we move on to our sort of final questions, I just want to make sure everyone has had a chance to share, their work and research about brain health and prevention. Does anyone have anything they want to add?
Well, I do feel, and I don't want to be a buzzkill here, but there are associations, and then there are rigorously proven therapies. And I think that it is absolutely fair to say that brain health will be promoted by the same things that promote cardiovascular health. So if you have blood flow issues in your brain, which can cause dementia, and you get Alzheimer's, well, it's going to be doubly worse. And I think that, a lot of the things that are obviously very good to do, appropriate diet, a consistent amount of appropriate exercise, socialization, staying busy, these are all things that do promote brain health and resiliency. And those will help stave off dementia and stave off the symptoms of dementia, but will they actually prevent Alzheimer's? I'm not so sure.
Yeah. I mean, that's, and that's why, again, trials so important. Getting all this information is so hugely important. As we sort of reach the final parts of our discussion, I was hoping we could just go to each of you to share, something that you're excited about, any breakthroughs you've heard about, the thing that is sort of driving your work right now. Dr. Shah, why don't we start with you? What sort of new research do you find exciting on the horizon?
There's so much that's really exciting. And so I wanted to just dovetail on what Dr. Asen said. I know that that there's a lot of hope out there, and and exercise and diet, yes, it won't fully prevent dementia. I think we're also seeing in the pandemic, the isolation, the decreased activities and socialization has caused progression. And research will probably come out and demonstrate how dementia has progressed faster during the isolation. And so probably the socialization is slowing things, and the exercise and all those activities. But yes, it doesn't fully 100% prevent, but it definitely decreases the risk. So in terms of excitement, there's a very controversial medication that Dr. Asen mentioned earlier. And I'm not just excited about that because it is controversial, but I'm excited for all of this discoveries that are coming forward after that too. The diagnostics that are now becoming available that Dr. Asen mentioned, really, as we said before, the way we used to have 100% certainty of a diagnosis of Alzheimer's disease was pathology with a piece of the brain. And through the years, we've had spinal fluid diagnostic measures and PET scans that help diagnose that amyloid and tau protein. And now with plasma, blood, so much more confirmatory. So we're really moving forward in diagnosis and treatments. And I think that we're really opening the door. It's exciting, but there's a lot more to discover, namely what I said about the heterogeneity of this disease. And we really need people to volunteer. And that's why I'm so passionate at Stanford that I run so many different clinical trials to offer different diseases, different stages of diseases, so that we can find that cure that would fit you and your family. Thanks.
Amazing. Dr. Asen, any closing thoughts?
Sure. So the ATRI is currently must have 4 or 5 different anti-amyloid and anti-tau agents. Some of them are intravenous, some of them are oral, and is engaged in treatments for symptoms, and is engaged in some work on better diagnosis, earlier diagnosis, correlation of these blood tests and PET scan with one another. Just to answer a question you had earlier about how to find a trial, I would suggest you look at our website, which we're in the midst of revamping right now, because we have 30 major centers around the country that are participating in our trials, as well as 70 other around the world. And you can locate, we have a map, interactive map, that so you can locate where those trials are occurring.
Amazing. Dr. DeLeon.
Yeah, I think I'll echo what's been said. I'm excited for medications that will hopefully come on the horizon. And I think the idea of being able to diagnose without having to use a PET scan or without having to use a lumbar puncture is really exciting and might open up ways to diagnose people in different settings, right, than having to come to a tertiary care center or university type of hospital. And I think I'm really hopeful that we're going to do better with the diversity of people that we see in research, just so we can really have these results and these treatments, fit a lot of different people.
Yeah, amazing. Dr. Kremen.
So what I'm really excited about is just seeing, even in the past couple of years, the variety of the different types of trials that are making their way from the very beginnings of phase 1 now into phase 2. There's a huge phase 2 really looks at safety and efficacy. Phase 3 is where you're looking at, really seeing if an investigational product really is helping slow down cognitive and, functional decline. But you'll get there. Things typically will go phase 1, phase 2, phase 3. Anyway, what's really exciting is there are so many mechanisms now. Before, we've all this work that has come out, and now we are in the amyloid, like we're looking at it, all this work went into that. Now we've gotten to see what does amyloid, how's that happen? Now we're getting to see tau. And what's coming behind it is all these other things. Let's look at metabolism. Let's look at, reducing inflammation. Let's look at all these small molecules that can get into the blood-brain barrier and really try to get into the brain. So what's really lovely is to see how many different aspects of these drugs that are in development and that are being tested, because it's not going to be one drug in the end. Probably it's going to be a multi-system type of therapy, just like when we were treating HIV. You need to get the Alzheimer's, anything neurodegenerative from a multiple processes, because there's multiple processes that probably lead to neurodegeneration in the first place. So you're probably going to need something that attacks amyloid and tau and metabolism and inflammation. And we don't know yet. We're just at the cusp, but it's so exciting to see that hard work come to fruition now that we get to, try to get people into studies and see what's going to work. It's really exciting.
Yeah, for sure. Dr. Perrin, what do you think?
I was just looking at some of the questions, so I'll just try to tie that in also with the question that you're asking. But
great.
So people are asking, after you get the diagnosis of Alzheimer's disease, how do you manage from there? So usually you do start with medications that are available now, and then see what type of things they need at home, what type of assistance, where they're at, are there any behavioral changes. And then there are trials for these too, if needed. So if medical management doesn't work, then they can participate. And then they can participate either in, not to just focus all the time on trials, but they can participate in stuff that involves more research or involves medication. And then monitor closely and see what type of support they need, family support, additional needs within the home. And then also there's some people that have been asking about what type of supplements or additional diets like Bredesen protocol could that be used. And those are controversial. So some people choose to be a part of it, but there's no strong support for that. So I'm just trying to address some of those needs. So some people say, well, now that I have that diagnosis, should I follow the Bredesen protocol? So I can't say definitively that would be it, but there's some things to take from those protocols that are helpful. Then, that's something in regards to stroke. So can strokes affect your memory? So it's good to screen, are there any vascular risk factors? Has there been a history of strokes? We do imaging to help when we're making the diagnosis of Alzheimer's disease. And then, like we've already discussed, having a healthy diet, making sure that your vascular risk factors are under control can also affect Alzheimer's disease. So those things need to be managed. At UCLA, we offer a broad spectrum, just to plug UCLA here too. We have a Kagan clinical trials team, and they have clinical research that focuses on imaging studies to help provide more information, neuropsych testing. And then we have studies that work with medications. We're going to be having a diabetes medication, anti-amyloid, anti-tau medication that are part of our studies that are coming. So those are some of the management plans that are helpful. And once someone has a diagnosis, they can think about participating and see what's right for them, weighing the risk versus the benefits. I hope I didn't take up too much time.
No, oh my gosh, no, I'm glad that you addressed some of those questions, and I'm glad that you were able to shed some light on some of that. And, this has been such an amazing discussion. Certainly, I'm sure we could talk for much longer, but I am so appreciative of being here and having this conversation with all of you. This has been really educational. And again, everyone listening will share everything that was said here today.
And Lauren, I just wanted to personally thank you from Kensington Senior Living just for moderating today, and wanted to thank Dr. Shaw, Dr. Asen, Dr. De Leon, Dr. Paran, Dr. Kremen, just for your great work and your commitment to the research and education. This was absolutely wonderful, and we're just honored to be a part of just educating our community and being a great resource. And just thank you also to UCLA, UCF, HFC, Cedars-Sinai, UCSF, and Stanford. And together we're just giving back and really helping the community in a space where they need more resources and need more education. And just thank you to all of you. And thank you to everybody joining us today. We're wishing everybody a wonderful and safe holiday, and wishing everybody a great night. So thank you.